I am Mohab Al-Mahdi. I'm a neurosurgical specialist at Soba University Hospital of University of Khartoum. And I'm from Sudan, and it's my pleasure today to present to you my talk about the venous anatomy of the brain. Let me share my slide. It is my pleasure again to meet you in this evening. And today my talk will be about the venous drainage of the brain. It is a bit complex, and it is more complex than the arterial anatomy of the brain. About the plan of our presentation today, we'll go through introduction, generality, we'll have a descriptive anatomy, and then we have certain clinical application, and then we'll conclude with our presentation, and at the end you will find the references that I used in this presentation. What is my objective today? It is to study the anatomy of the venous drainage of the brain and to understand its clinical correlation and to review some of the pathologies that affect the venous system. Usually, the venous drainage of the brain it goes through a complex way. We have cortical vein, i.e., a vein that drains the surface of the brain. We call it a cortical vein. Those veins that run over the surface of the brain. Those cortical veins will converge into bigger channels. We call it dura sinuses. Those sinuses, they run through the two leaflets of the dura along the inner surface of the cranium. We call it dura sinuses. We have different types of dura sinuses. Some of them are single and some of them are paired. Then the final drainage will go through the internal jugular vein. The internal jugular vein is the main venous outlet of the venous drainage of the brain. So we can divide the venous drainage of the brain into a cortical vein system and dura sinus system that is finally drained into two internal jugular veins. You can see here that we know that the brain is covered with certain coverage. We call it meninges. We have the pia and the arachnoid and the dura. And the dura, we know that the dura, it has certain reflection. We call to divide the intracranial cavity into a compartment. We have the tentorial or the tentorium, which divides the cranium into a supratentorial part and infratentorial part. And we have the fossa cerebelli that is divide the hemisphere into two divisions. At the base of those reflection of the dura, we found a triangular space. We call it the dura sinus. So the dura sinus is usually at the base of a reflection of the dura, especially at the base of the fossa cerebelli, and this is called the superior situs sinus. And we have a dura sinus along the attachment of the tentorium cerebelli. We call it the transverse sinus. We have other sinus at the edge or the inferior edge of the fossa cerebelli. We call it the inferior sinus. Another important thing that we can see here in the image, that along the superior situs sinus, we have an outpouching of the arachnoid inside the superior situs sinus. This outpouching, we call it arachnoid villi, which is help in the reabsorption of the CSF back to the venous drainage. We know that the CSF is formed inside the ventricle by the choroid plexus, and it goes through a certain pathway from the lateral ventricle to the third ventricle and then to the fourth ventricle before it goes to the superficial cortical surface to cover the brain, and then it goes back to the venous system through those arachnoid villi that is enter the dura sinuses. So the first sinus we have, as I said, we have cortical veins that is run over the surface of the brain, whether it is the lateral surface or the medial surface or the basal surface. Those veins will converge into a sinuses. This is the superior sinus. It is a midline structure. It runs along the midline along the base of the fox from just behind the frontal sinus and go back all over the midline up to an area we call it torcular hypophyly. And you can see that the veins along the lateral surface of the brain, they converge into that sinus with different angle. If we have this, this is a lateral view where we can find that also we can see that the cortical veins that is converged into a superior sinus. And if we follow the superior sinus, it will go back into this area where it is joined by the transverse sinus, which is in the base of the tentorium, and with the occipital sinus to make a confluence of sinuses. We call it torcular hypophyly. This torcular hypophyly also receive a sinus or dural sinus that's come from inside. We call it the stress sinus, and we see it in the next slides. So let us start. From this image, we can see the lateral surface of the brain, and you can appreciate that the veins or the cortical veins, it runs over the surface of the brain and in different direction. In this image, you can appreciate that the artery, merely the branches of the middle cerebral artery, it usually goes and deep inside the sulci of the brain, while the vein, it usually runs superficially over those sulci. We didn't find the vein that is go and deep inside the sulci. They usually run superficially over the surface, while the artery, they usually enter inside the sulci and then go out and run through run along the configuration of the brain. This is the superior sinus, and the superior sinus, as I said, it is started anteriorly, just behind the frontal sinuses, and end posteriorly, and it is receive the veins from the superior part of the lateral surface, and also the superior part of the medial surface of the brain also. And in the middle part of the superior sinus, we can find sometimes an extension, lateral extension. We call it a lacunae. So usually in the middle part or the central part of the superior sinus, there is some extension of that sinus along the dural leaflet laterally to make a lacunae. So those lacunae, it is usually on the middle part of the superior sinus. This is an image of the medial aspect of the brain. We can appreciate that is the corpus callosum, and this is the medial aspect of the frontal and parietal and occipital lobe. Along the inferior edge of the fox, we have here we have the fox cerebelli, and along the inferior edge of the fox cerebelli, we have a sinus. We call it the inferior sagittal sinus. It is parallel to the superior sagittal sinus. The superior sagittal sinus is usually run along the upper edge of the fox, and the inferior sagittal sinus runs along the inferior edge of the fox cerebelli. And as it goes back, it is joined by a vein. We call it the vein of Galen, or the great vein of Galen, and before it become a straight sinus. The straight sinus is a sinus that's run along the attachment of the fox cerebelli with the tentorium. We know that the fox cerebelli and the tentorium have a midline attachment, along that attachment, we have another sinus, we call it the stress sinus. So up to now we have a superior sinus, as I described, that's run along the superior edge of the fossa, and we have the inferior sinus that's run along the inferior edge of the fossa cerebelli, where it's joined by a vein, or called the vein of Galen, that is to form a sinus along the attachment of both the fossa and the tentorium, which is called the stress sinus. This is an inferior view of the brain, where we can see both the occipital lobe and the two cerebellar hemisphere. Here we can find a confluence of sinuses, where we have both the superior sinus and the two transverse sinus, and sometimes the occipital sinus. Those four sinuses, along with an inner sinus that's called the stress sinus that's come from inside, they form a confluence of sinuses. We call it a torcular. This torcular, it is a midline structure where we have all those sinuses, they came together to make connections. Usually, the superior sinus can have different drainage. Sometimes it has an equal drainage to both transverse sinuses, or can be dominant drainage to one of them. But in most of the cases, it has a dominant drainage to the right side. So the superior sinus, in most of the cases, it has a dominant drainage to the right side transverse sinuses. This is a lateral view where we can find after the torcular herfuli. If we follow the transverse sinus, it runs along the lateral attachment of the tentorium, and it receives also some of the cortical veins that drain the lateral surface, the inferior part of the lateral surface of the brain, and also some venous drainage from the base of the brain before it reaches a point here. We call it an asterion. Asterion, it's a craniometric point along the lateral aspect of the skull before it forms a sigmoid-shaped sinus. We call it the sigmoid sinus. This sigmoid sinus, it will run down and form a sigmoid shape with a sigmoid configuration, and at the end it will form a enlargement. We call it a jugular bulb before it exits through the internal jugular or the jugular foramen to form the internal jugular vein. This is another picture of the venous drainage of the lateral surface of the brain. And as you see, the venous drainage of the lateral surface of the brain, it follows different direction. We have the cortical vein along the superior aspect of the lateral surface. All of those cortical veins, they go towards the midline, towards the superior sinus. Those of the inferior part of the lateral surface, they goes down towards the transverse sinus. And we have a central part of venous drainage that goes into a venous collector called the superficial middle cerebral vein. We have a vein, a larger vein along the superior, along the lateral sulcus or the sylvian sulcus. We call it the superficial middle cerebral vein, or sometimes we call it a superficial sylvian vein. This vein will go along the sylvian fissure and collect the cortical vein that is mainly the operculum that is covers the insula, or the cortex that is adjoining the sylvian fissure. So the venous drainage of the lateral surface of the brain, it either goes up towards the superior sinus, or down towards the transverse sinus, or medially through the superficial middle cerebral vein that is also called the superficial Sylvian vein. This superficial Sylvian vein, with its cortical drainage, sometimes it forms an anastomotic connection with both the superior sinus and the inferior sinus. That anastomotic connection or anastomotic vein, we call it the vein of Trollad. This is the veins that connect, we call it the anterior superior anastomotic vein that connects the superficial Sylvian vein with the superior sinus. And we have also a large connecting veins that connects the superficial Sylvian vein with the transverse sinus. We call it the vein of Lavet. So you can see from this image that we have, it is usually for the venous anatomy to have a lot of variation. So sometimes we can find an equal dominant both the vein of Trollad and Lavet. Sometimes one of them will be more dominant. Sometimes we can they will be absent, and sometimes one of them will be absent and the other will be present. So in general, the lateral surface of the brain, it is drained into 3 directions. The superiorly towards the superior sinus, and inferiorly towards the transverse sinus, and medially towards the superficial Sylvian sinus. And the superficial Sylvian sinus will make sometimes an anastomotic connection with the other 2 sinuses through the vein of Lavet or the vein of Trollad. This image, in this image, we can see that is the superficial Sylvian vein, which is collected it is formed by the convergence of the cortical vein along the superficial aspect of the Sylvian fissure. In the depths of the Sylvian fissure, along the surface of the insula, we have a deep middle cerebral vein or deep Sylvian vein. It is run in the insula that is buried inside the superficial operculum, and this vein will also drain mainly the insular surface. So on the lateral surface, we have a superficial Sylvian vein that is mainly drains the operculum, and we have also a deep Sylvian vein that is drained the insula. This is the medial aspect and the medial aspect and the basal aspect of the temporal loop. We can see here that we also have the cortical veins that run along the superior aspect of the medial aspect. It runs up towards the superior sinus, and we have those veins along the base of the temporal loop and occipital loop. It runs laterally towards the transverse sinus, but we can see another set of veins. This is the inferior. We have a deep system. This is what we discussed in the previous slide. We call it a superficial system. We have another venous drainage or cortical vein. We call it the deep venous system. It's drained the ventricular system and deep white matter and gray matter. Mainly, we can see here that this is the foramen of Monro. We have an arteries that run inside or on the roof of the 3rd ventricle. We call it the internal cerebral vein. This vein, it is drained the ventricular system and the deep white and gray matter. And we have another vein that runs along the basal cistern or the base of the brain. We call it the basal vein of Rosenthal. Those 2 veins, they will converge to form a great vein of Galen or the vein of Galen. This 2 veins that is converged into a great vein of Galen, we consider them as a deep venous drainage. They drain mainly the ventricular system and the adjoining deep gray and white matter. And those veins, after forming the great vein of Galen, they join the inferior sagittal sinus to form the straight sinus. This is the basal surface of the brain, and we can see that the drainage of the basal surface of the temporal and occipital loop mainly runs laterally towards the transverse sinus, and the venous drainage of the frontal loop, they anteriorly will go towards the beginning of the superior sagittal sinus. This is another image of the deep venous system. As I said, we have the vein of Galen, which or we call it the great vein of Galen. It's formed by two veins, larger veins. One of them we call is the internal cerebral vein that is run along the ventricular system. It forms at the foramen of Monro by the septal vein and the anterior caudate vein, and the septal vein, where they join in the foramen of Monro to form an internal cerebral vein that is run along the roof of the third ventricle and run posteriorly, and it has some tributary from the lateral ventricle. The basal vein, the other vein, which is called the basal vein of Rosenthal, it formed in the inferior surface of the brain by an deep medicerebral vein that is we discussed that drains the insula, and an artery and a vein that is follows the anterior cerebral artery. We call it the anterior cerebral vein. The anterior cerebral vein, it comes from the anterior aspect of the medial surface of the brain and joins the deep medicerebral vein to form a basal vein of Rosenthal. This vein will run along the basal cistern of the brain, and it at the posterior aspect it will join the internal cerebral vein to form a great vein of Galen. The great vein of Galen, it will join the straight sinus. And this system of those two internal cerebral vein and two basal vein of Rosenthal that forms the vein of Galen, it is considered as a deep venous system. It drains mainly the ventricular system and the deep gray and white matter of the brain. This is another image that shows the two internal cerebral veins coming from the roof of the third ventricle and the basal vein of Rosenthal that's run along the lateral aspect of the midbrain along the cistern, the premesencephalic cistern, to form the vein of Galen. Here, the vein of Galen will join the straight sinus that's run along the junction of the falx cerebelli and the tentorium, and which is also receives the inferior sagittal sinus. And here it is the tercal hyphale where we have on both sides the transverse sinus. This is another image to show the basal vein of Rosenthal. It is formed here inferior to the anterior perforated substance by the joining of two veins, the deep middle cerebral vein and the anterior cerebral vein, and it will run along the cistern around the midbrain and run posteriorly to join the internal cerebral vein before forming the great vein of Galen. This is regarding the surface of the cortical vein of the brain, and as we discussed, we have both superficial and deep system, and the dural sinuses along the convexity of the brain. We have another set of dural sinuses along the base of the skull. The important one is the cavernous sinus. The cavernous sinus, it is a paired dural sinuses along the side of the cella, and those sinuses are unique because they contain, in addition to the venous system, they contain an eloquent or important vascular and neural structure. We can see that the cavernous sinuses, it is usually it's formed by the separation of the two leaflet of the dura, and would form a two compartment along the lateral aspect of the cella. They form the lateral wall for the pituitary gland, and along the lateral wall we have certain nerve or cranial nerve, namely the oculomotor nerve and the trochlear nerve, and the first two division of the trigeminal nerve, the ophthalmic division and the maxillary division. Although those four nerves will run along the lateral wall of that dural sinus, and inside the cavernous sinus we have the internal carotid artery. A portion of the internal carotid artery will run through the cavernous sinus, and the only cranial nerve that runs through the cavernous sinus is the abducens nerve. So the cavernous sinuses are paired cavernous sinuses that's found along the side of the cella, and they found on the lateral aspect of the pituitary gland. They usually connected between, there is the connection between the two sides through the cella. We call it the intercavernous connections, and those cavernous sinuses, they contain an important neural and vascular structure, namely the oculomotor, trochlear, ophthalmic, and maxillary branch along the lateral wall, and the abducens nerve. It runs through the cavernous sinus, and we have the carotid artery that is enter the skull through after coming through the carotid canal. It will enter through the upper opening of the foramen lacerum, and from there it will run through the cavernous sinus before it exits medial to the anterior clinoid. This part from the foramen lacerum to the medial aspect of the anterior clinoid, we call it this segment, we call it the cavernous segment of the internal carotid. The cavernous sinuses, it is also unique in that it has different tributary and different drainage. The cavernous sinuses, it receives drainage from the orbit through the superior and inferior ophthalmic vein and the central vein. It has also a tributary or a sinus that's run along the sphenoid ridge. We call the sphenoparietal sinus. Also, we have the middle meningeal vein. It drains also to the cavernous sinuses. And as I said, the two sides, they connect through the cella through intercavernous connection, and also along the back of the clivus through the basilar plexus. And the main outflow of the cavernous sinuses is through two sinuses. The one run along the superior edge of the petrous bone. We call it the superior petrosal sinus, that is run back to join the junction of the transverse and the sigmoid sinus. So the transverse sinus, after joining the superior petrosal sinus, then it will call the sigmoid sinus. And we have another outflow of the cavernous sinus. We call it the inferior petrosal sinus. It runs downward towards the internal jugular vein and join the sigmoid sinus out of the internal jugular foramen. The sigmoid sinus, after exiting the jugular foramen, we call it the internal jugular vein, and the first venous drainage to the internal jugular vein will be the inferior petrosal sinus. This is another image to show us the connection and the drainage and the tributary and the drainage of the cavernous sinus. As you can see that we have an anterior drainage from the superior or anterior tributary coming from the superior ophthalmic vein, central vein of retina, and the inferior ophthalmic vein. We have some tributary coming from the sphenoparietal sinus the superficial middle cerebral vein, the middle cerebral vein, middle meningeal vein, and the drainage is mainly through the superior petrosal sinus, which goes back to the junction between the transverse sinus and the sigmoid sinus. And then we have the inferior petrosal sinus that's drained into the internal jugular vein. In the floor of the middle cranial fossa, the cavernous sinus, it also has connection with some plexuses that outside the cranium along the inferior aspect of the skull base, namely the pterygoid plexus along the pterygoid muscles, and the pharyngeal plexus along the wall of the pharynx. This is about the supratentorial venous drainage. If we discuss the infratentorial venous drainage or the posterior fossa venous drainage, we can see that the venous drainage in the posterior fossa or in the infratentorial compartment, along the surface of the brainstem, we have a channel of horizontal channels that run along the sulci of the brainstem, and vertical channels that run along the sulci of the brainstem, and another set of horizontal channels that is connect with each other. And we have a cortical veins that run along the surface of the cerebellum. Those veins, they usually converge into different direction. The veins from the midbrain and the superior aspect of the cerebellum, they will go towards the great vein of Galen, and those from the inferior aspect of the cerebellum, and they will go toward the tertiary hypophyly, and the venous drainage from the anterior aspect of the brainstem and the anterior aspect of the cerebellum will go anteriorly towards the petrosal sinus. So the venous drainage of the posterior fossa will follow three groups: a superior group that goes toward the vein of Galen or Galenic group, and we have the vein on the inferior surface or the posterior surface will run towards the tertiary hypophyly, and we call it tertiary group, and the vein from the anterior aspect will run anteriorly towards the superior petrosal sinus, and we call it petrosal group. Also, it is important to note that the venous drainage of the inferior aspect of the brainstem, it also has connection with the venous drainage of the spinal cord. So it's not unusual to see a pathology in the upper cervical region that affects the venous system, and the venous distension or the venous congestions can run up towards the brainstem. And also, if we have a pathology in the venous system in the posterior fossa, it can also have some reflection on the venous drainage of the superior part of the cervical spine. So it is important to note that we have also connection between the venous drainage of the posterior fossa with the venous drainage of the spinal cord, especially the upper part in the cervical region. This is another image to show to you that we have different group of venous drainage, either into the torcular hypophyly or the vein of Galen, or towards the superior petrosal sinus. Regarding clinical application, we have certain craniometric or surface marker for the important venous structure. The important one is the sagittal suture. The sagittal suture is the suture between the two parietal bones. It runs from the prigma up to the lambda, and it marks the midline of the cranium. And the midline of the cranium, it give us a landmark for the superior sagittal sinus. And superior sagittal sinus is usually run in the midline, and sometimes can be deviated a little bit to the right side. On the posterior aspect of the skull, we have an craniometric point, we call it the inion, or the external occipital protuberance. This craniometric point, it make a surface marker for the terticular or the confluence of the sinuses. And from that, on this point, the superior nuchal line will give us a surface marker for the transverse sinus. So along the midline of the cranium, and we have the superior status sinus, and in the inion, it is give a landmark for the terticular, and from there, along the superior nuchal line, we have a landmark for the transverse sinus. It's important also to know that the bregma, which is the junction between the coronal and the sagittal suture, it marks the end of the anterior third of the superior status sinus, and from the bregma to the lambda, which is the joining point between the sagittal suture and the lambdoid suture, it marks the middle part of the superior status sinus, and from the lambda to the inion, we have the posterior third of the superior status sinus. Another important craniometric point is what we call is the asterion. Asterion is defined by the point that is formed by joining of three sutures. It make a Mercedes-like sign, and it is formed by the joining of a suture called the lambdoid suture and parieto-mastoid suture and the occipito-mastoid suture. Those three sutures will form an asterion, and which is give us a landmark for the junction of the transverse and the sigmoid sinus. When we investigate the pathology regarding the venous system, we request a brain venography. Brain venography is an imaging for the venous system. It either could be requested or can be done through a CT or MRI, or even with a catheter or diagnostic catheter. And this with injection of contrast, now we can see those venous structure. Here we can see the superior status sinus, the transverse sinus, and the sigmoid sinus. Here we can see the inferior sagittal sinus and the greater cerebral vein, and this is the straight sinus. So the brain venography, it is diagnostic imaging for venous system. Regarding pathology that is affecting the venous system, one of the classical conditions that we see in the neurosurgical emergency is the subdural hematoma, which is defined as a collection of blood underneath the dura, and it is usually of crescentic shape. And according to the age, it either could be an acute, where it will look hyperdense, or subacute, when it have the same density of the brain, or chronic, when it looks black. And the subdural hematoma, it has a different explanation for its pathology, but one of the theory of the pathology is bleeding from the bridging vein. So the subdural hematoma, it's caused from a minor trauma that is lead to a tear in the bridging vein, especially in the elder person, that lead to collection of blood in the subdural space. Sometimes we have patient with the breast fracture, and it is important to know if the breast fracture is related to important venous structure, especially when we have, for in this image, we can see that we have a comminuted breast fracture that is near the midline. So we can expect that we have some compression or some injury to the superior sagittal sinus. As you can see here, we have a filling defect of the severe sinus along the fracture. So in this situation, we should be prepared for possible venous sinus injury, and we should be prepared for that situation. So it is important to use our anatomical understanding of the location of the severe sinus in planning surgery, especially when we are near an important venous structure. Sometimes we can see, although the epidural hematoma is usually, or most of the cases, it comes from an arterial source, from the middle meningeal artery, but sometimes when we have a fracture or a linear fracture that's transverse the superior sinus, sometimes we have an epidural that is come from a venous source, like this epidural hematoma. So epidural hematoma over the superior sinus, it raises the suspicion that is the source of the bleeding is from the superior sinus. We have certain approaches that is related to the dural sinuses. We have the parasital approach. The parasital approach, it is used usually to reach, to go through the interhemispheric fissure, and we have a craniotomy that is formed along the midline. Sometimes we cross the midline to the other line, and so we should be careful when we are doing craniotomy, especially over the superior sinus, not to do to make an injury to the superior sinus. And in this, after we make the craniotomy, now we can find the superior sinus on the medial aspect with the draining vein coming into it, and we can go through the interhemispheric fissure. So the parasital approach is one of the approaches that is related to the venous system, and it is we should take care of the superior sinus, and we should consider it as an important structure while planning our approach. Another craniotomy that is related to venous structure is the retrosigmoid approach, and from its name, it is a craniotomy that is formed behind the sigmoid sinus, and it is usually used to approach the posterior fossa, especially the cerebropontine angle. And as you can see, we in this approach we use the asterion, which is the landmark of the confluence of the transverse and the sigmoid sinus, and we'll make our craniotomy below and behind that point to avoid injury to the transverse sinus and the sigmoid sinus. What will we do if we have an injury to the one of the dural sinuses? The injury of the dural sinuses, it is very serious because the patient can deteriorate due to the excessive bleeding, or because those veins are non-collapsible, and they are prone for air embolism, where it's a condition where an air is stuck inside the sinuses, and from there it will go to the heart and make an embolus, which can lead to hypotension. So, we should be very careful when we are dealing with injury or injury to the dural sinuses. We should cover the sinus with any cotton patty, and we should fully irrigate this place to prevent the bleeding and to prevent the air from entering the sinus. After that, we should plan for the definitive repair for that sinus. We can either repair it directly with suture, or we can make an midline, cut a leaflet from the dura and reflect it over the defect, and we suture it. And we can sometimes use a graft from the muscles or the gallia, and we suture it over the defect. And in special situation, we can just obliterate that segment by suturing proximal and distal to that injury. So it is important to know the technique of how to repair dural sinuses. We have other conditions that affect the venous system of the brain. We call it the dural sinus thrombosis. Dural sinus thrombosis is it's the thrombosis that's occur in the dural sinuses, and it usually occur in a situation with hypercoagulable status that is lead to a thrombus formation inside the dural sinuses. It can occur in the superior situs sinus or can occur in the transverse sinus, and usually it will appear in the CT in a hyperdense lesion. We call it delta sign, and this we can see the hyperdensity along the transverse sinus, which signify a thrombosis. Regarding the pathophysiology or the consequence of the dural sinus thrombosis, the obstruction of the dural sinus will increase the venous pressure. This will impair the CSF absorption and increase the intracranial pressure. And also the increased venous pressure will lead into a venular and capillary pressure that will lead to venous infarction and venous edema or vasogenic edema, and which can also lead to rupture of the venous and capillary rupture with subsequent parenchymal hemorrhage. And capillary perfusion also will, the increased venous pressure will ultimately affect the arterial pressure or the cerebral perfusion pressure, will lead to more edema. So we enter a virtuous cycle. And regarding the clinical features, it depends upon which signs that is closed. Sometimes the patient can present with motor deficit or seizures, like in severe situs sinus. For example, in the sigmoid sinus, the patient can present with tinnitus, neck pain, and cranial nerve palsy. If the cavernous sinus is thrombosed, it will lead to venous congestion in the orbit, and the patient will present with orbital pain, chemosis, proptosis, and cranial nerve that is run along the cavernous sinus. Cranial nerve palsy of the cranial nerve that runs through the cavernous sinus. Sometimes we have a pathological connection between an artery, mainly the meningeal artery, that make a direct connection or fistulous connection with the dural sinuses. We call it this condition, we call it the dural arteriovenous fistula. This leads to increased pressure inside the dural sinus with secondary reflux of the vein along those veins that is drained to that sinus. So usually the cortical veins that is drained to that sinus, it will drain away from the brain. But if we have that pathological arteries that form a connection and increase the pressure, now we have a backflow of the blood along the cortical vein that lead to venous hemorrhage inside the brain. Sometimes we have an embryological or developmental anomaly of those venous structure, like we have a vein of Galen aneurysmal malformation, which is a dilatation of the and malformation of the great vein of Galen, and it usually appear earlier in life, especially in neonatal patients, and where they present with progressive head enlargement, and due to the high flow along that malformation, this will lead to a cardiac dysfunction, and the patient will present also with heart failure. So in conclusion, understanding the venous anatomy of the brain is crucial. Venous pathology has wide spectrum of clinical presentation, and surgical planning should respect a decent venous anatomy. Thank you very much.
Thank you so much, Dr. Mohab, for this wonderful presentation. I believe that we have some question to ask Dr. Mohab. So if you have any question, you can feel free to unmute your mic and ask your question or any comment.
Hello, everyone. Just to comment that this was a really great presentation and it was easy to follow, especially for us medical students. So thank you very much for preparing and organizing this.
All
Thank you.
right. Thank you, Lauren, for that. Do we have any other comment or question from anyone regarding today's presentation? Okay. Well, I just want to say, Dr. Muhab, I don't know, is there like a mnemonics or something that, you know, I feel there's a lot of information here that could help medical students, you know, to try and remember some of this stuff and the various sinuses and veins. Is there like any tips or mnemonics that could help to capture the volume of the information?
Pardon, I didn't got you, please.
Okay, so I was saying that looking at the volume of the information about the sinuses, is there like a mnemonics or any tips that could help medical students to retain and to remember some of these?
I hope so. Unfortunately, I don't know a mnemonic or mnemonic for that purpose, but I can share with you one if I found one like this.
All right, thank you so much. So, do we have any other question or comments from our panelists? Okay, so if there is no any question or any other comments, I think we can bring the meeting to an end. I really want to appreciate the presence of everyone, and special thanks to Dr. Muhab for this wonderful presentation. I think it has been a great day. It has been a wonderful session. Thank you everyone for joining us today. We'll meet again next week.